All right, so up next, we have Jennifer Johnston, who's actually one of Yale's own. And we've invited her today to talk about her work here at Yale and some of the mechanisms. So we've talked about assessment, we've talked about prediction and prevention, but a lot of the questions also remain about what are the underlying reasons some people make suicide attempts and some people do not. And so Jennifer is going to talk with us today about her research here in one of the labs at Yale. She's a researcher. She's also a clinician in private practice here in the area with expertise in emotion regulation difficulties and suicidal behaviors in youth and adults. In the sake of time, I will go ahead and let her talk a little bit about what her research is. So please join me in welcoming Jennifer Johnston.
Okay, I was told that if I turn the microphone off, it's on me to turn it back on. So the first thing is successful. I turned the microphone on and everyone can hear me. Thank you so much, Emily, for the introduction. And I am just so excited to be here today because I've actually been an attendee of this conference in years past and just really think that Emily and Seth and everyone involved here in the NEA-BPD and at Yale do such a marvelous job of really putting on such a high-quality educational conference for us each year. And so I'm excited to be a part of that this year. And I'm also excited to be able to share with you some of the more recent research that we have in regards to the neural circuitry underlying suicidal behavior. Because I really is a passion of mine to be able to speak in settings like this, where we're kind of trying to bridge that gap between research and practice, right? Because that's what research is supposed to do, is to help us apply things in clinical settings. So I'm glad to be able to speak here. And I thought it might be helpful for me to give you just a little bit of background about myself and kind of how I came to be here, just to provide some context. So my background actually started out much more clinical. My graduate program, there was certainly the idea of link between biology and symptom and brain and behavior. And that's where my interest in research began. But I trained in Dialectical Behavior Therapy and then worked for several years in clinical, intensive outpatient settings. And I never really lost sight of my interest in research, though. And I think this really crystallized for me. One day, I was sitting in front of a client of mine who was very highly suicidal at the time. And she just looked at me and she said, "Why am I like this?" And really what she was asking was, why was she thinking about killing herself? Because she understood that she had a lot of friends and a lot of peers who were struggling with things at home or at school, and yet they weren't thinking about killing themselves. And she wanted to understand why. And I knew that I could answer her question in part based on psychological theory, my knowledge about her past, and if I was really good, I might be able to say something to the effect of like, well, there are neurons and stuff, you know? But I couldn't answer her question in any more detail than that, and I knew that I wanted to. So that's when I contacted Dr. Hilary Blumberg here at the Mood Disorders Research Program at Yale and asked her if I could come learn about and contribute to her research here. And God bless her, she said yes. And I've been here for about 4 years, and I'm really excited to share some of what I've learned and what we've really studied in our group here at Yale. So today I will be talking about the neurobiology of suicide with an emphasis on neuroimaging. And to do that, I'll start out with just a little bit of a synthesis on the prevalence and development of suicide behaviors as it applies to my talk today. Then I'll give you just a little bit of an overview of some of the methods used in neuroimaging and what they've told us then about suicide behaviors across all diagnoses in general. From there, we'll drill down into the very specific diagnosis of borderline personality disorder and look at which of these findings might be related to this diagnosis. And then we'll look at how these findings might compare across other psychiatric diagnoses. And I'll just use the work being done in our group and the focus of my research in bipolar disorder as one point of comparison. And then lastly, I'll try to look at how neuroimaging might help us understand and prevent suicide and how we can use our understanding of some of the neural circuitry in more clinical settings in a clinical application. So again, all of us here today realize that suicide is a very serious and growing problem. And we've heard a lot of statistics today, so I'm not going to go through more, just a couple that apply to what I'm going to talk about here today. So we've heard now a few times that more than 40,000 Americans will die by suicide each year. And that actually means that in 2014, someone died by suicide every 12.3 minutes. And in this slide, it shows that in 2014, suicide was the 10th leading cause of death in all Americans. We've seen this before. But if we limit that to younger age groups then, as we've heard already today, in children, ages 10 to 14, in 2014, so it varies a little bit by year, but it was the second leading cause of death in children and adolescents, ages 10 to 14. And it remained the second leading cause of death in 2014 in ages 15 to 24. And so these charts that I just showed you weren't actually to scale, so to give you a better sense of how many deaths might be attributable to suicide within each age category, I'm going to show you a graph next that breaks it down by the age interval. And so what really jumps out to me, as I'm sure it does to you, is the dramatic increase in number of suicides, or number of deaths by suicide, rather, during adolescence and young adulthood. So it's not just that it is the second leading cause, if that's a just, but that there's a dramatic increase during this time period. And yes, as we saw later, also, it still continues to rise, and the risk continues to rise later, but there is this increase during adolescence and young adulthood. And that gets even more sobering when we consider that we know that there are approximately 25 suicide attempts for every one suicide in adults, ages 18 and over. And then again, if we limit it to younger age groups, approximately 100 to 200 attempts for every one suicide in young adults ages 15 to 24. So why am I emphasizing this again? And besides the fact that it underscores that suicide is a very serious problem that can't be ignored, the fact that there is an increase in number of suicides during adolescence and young adulthood really suggests that this is a really critical developmental period for the development of suicide behaviors. And so we want to think critically about what's happening during this time period. And when we think about adolescence then, we're thinking about obviously a lot of physical maturation and growth. In puberty, we're thinking about the many effects that the hormones can have on the brain and body. We're also thinking a lot about social development and identity development and the many perils that can exist in our interpersonal relationships during this time period, as talked about in Dr. Kane's talk. But what we also know is that this is actually a very critical period for brain development, beginning in adolescence and on into young adulthood. And this suggests in part then that suicide behaviors, along with some of, as we've shown in other studies, other risky behaviors, might be able to be linked to specific neural mechanisms. And this really is what neuroimagers are trying to do. It's a big task, but we're trying to understand the biological mechanisms underlying the development and the maintenance of suicide behaviors. So to begin to understand how to do that, I want to give you, I think it's helpful just to have a little bit of a sense of some of the methods that we use in neuroimaging and looking at what they have told us about suicide behaviors across all psychiatric diagnoses so far. So when we think about studying the brain, you can really kind of focus in on looking at it in two different ways. You can look at the structure of the brain, or what it does, or how it functions. And then within each of these two categories, we have different methods as well. So when thinking about structural, we can look at the gray matter, like in this picture. And this essentially helps us look at the brain anatomy. So the different size and shape of different structures, like the red and yellow trace structures there. And the technique most often used to look at this is magnetic resonance imaging. Alternatively, you can look at white matter, which essentially is the myelinated axons that provide the connections between the different brain structures. And here's a picture of what that might look like. A more recent technique to look at white matter is called diffusion tensor imaging. And it's a really exciting technique because it helps us look at very specific white matter tracts in the brain and understand their structural integrity, or how well they're maybe able to conduct signal. And here is a picture of an example of one specific white matter tract in the brain. And I like this picture. I think it's pretty cool. It's a lot of the different white matter tracts in the brain. So we can use these structural techniques then to compare the anatomy of the brain between groups, like between people who attempt suicide and people who don't attempt suicide, and look at whether or not the structural integrity might differ between these two groups. And again, we can also look at how the brain functions, and we have other techniques here. The first I'll talk about is functional magnetic resonance imaging. Essentially, this really just kind of helps us understand which neurons of the brain might be firing at any given point, and helps us understand how the brain might be responding to specific tasks or stimuli that we give them while they're in the scanner. Other fMRI techniques allow us to look at which regions of the brain might be kind of coordinating their action over time or communicating with one another. For example, in this image, this is a region of the brain during a scanning protocol that is coordinating with the amygdala, which is an emotional center of the brain. Then we have radioligand-based studies. The first is single photon emission computed tomography, and that's quite a mouthful, so I prefer SPECT, because that's easier. And then we have positron emission tomography, or PET, and these allow us to tag water or glucose molecules and understand how the brain is functioning. And these are also used occasionally to probe different neurotransmitter systems, as I'll talk about later today. And so as an example, in this picture, the areas of red and yellow are areas of decreased serotonin receptors, actually. So then, using some of these techniques, what have they told us about suicide behavior so far? Before we do that, though, I just really want to make sure we're oriented to the pictures I'm going to be showing. So this is obviously a brain with the different lobes of the brain. And you can see it's oriented as if I were standing sideways, with the front of the brain to your left and the back of the brain to your right. And if you were to cut the brain from top to bottom, you'd be able to see the internal structures of the brain. And the brain can be divided into more dorsal regions, or areas towards the top of the brain, and more ventral regions, or regions towards the bottom of the brain. All right, so now that we're oriented, let's look at what the studies have shown us about suicide behavior. And I'm going to start with some structural findings. And in a recent review written by our group, we looked at all of the studies looking at suicide attempters across all studies. And what we really saw then was a convergence of evidence implicating more frontal systems. And this included the dorsal prefrontal cortex, the ventral prefrontal cortex, the amygdala, and also other anterior limbic, which is kind of more emotional type connection sites. Also, we saw convergence in evidence in the white matter that connects these structures. And so these studies were mostly in adults, but there also was some overlap with adolescent samples, which suggests somewhat of an early genesis. And again, these areas of the brain are developing during adolescence and young adulthood, and so also are their functions then. So as a little bit of an example, kind of broadly, the dorsal prefrontal cortex has been linked to executive functioning, behavioral control type things. So we can see and maybe understand how adolescents might have a little bit more difficulty with long-term planning and inhibiting certain behaviors. Sir, that doesn't really sound like any of the adolescents that you work with. Whereas ventral regions, just relatively, it might be more involved in emotion regulation and motivational behavior. And again, we might be able to point to how adolescents may have slightly more difficulty with these things than perhaps older adults do. The ventral prefrontal cortex is highly connected with more of the limbic emotional sites. That includes the amygdala, which is an emotional center, and is very involved in emotional responding. The hippocampus, you may know, is involved in memory-related processes, including laying down emotional memories. And the insular cortex is a really complex structure, and it's kind of tucked up underneath the frontal and temporal lobes. And among other things, it's involved in internal monitoring of our affective and physical states. So if we move on now to some of the functional findings, we see a lot of overlap with the structural findings. So again, this is how the brain is now functioning. And that means that we saw a lot of findings in this frontal system. And this was during specific tasks. So during the processing of angry faces and happy faces. These aren't the real faces shown, but it gives you a little bit of a sense. And also during tasks that involve impulse regulation. So during risky gambling choices or motor inhibition tasks, we saw abnormalities in these frontal regions as well in attempters. Then we also saw a decrease in blood flow and glucose metabolism in these frontal regions, showing somewhat of a hypofunction of these regions. And as I mentioned before, some studies using radioligand measures can probe certain neurotransmitter systems. And the neurotransmitter system most often studied in suicide is the serotonin system. So in this slide, we're looking at the synapse, a serotonin neuron, and that's the space between two neurons. So we have the neurotransmitter is generated in one neuron, it's released into the synaptic space. It can connect with a receptor on an opposite neuron, and it can also be taken back up via the original neuron via this transporter here. And so studies in attempters have shown us that there are abnormalities in the serotonin system, in the synthesis of serotonin, in the receptor binding, and also the transporter binding. So that's great that we can identify these regional abnormalities. But what might it actually mean for us, and how does it relate to the symptoms that we're seeing? And this is where it gets a little bit more complicated, because up until now, I've been talking about suicide as if it's a very homogeneous concept, as if every attempter and a group of attempters is the same. And of course, we know that's not true, and we also know that what differentiates attempters within one diagnostic category could be very different than what might differentiate someone in a different diagnostic category. We already saw Dr. Stanley kind of point out the difference between people who maybe struggle more with depression versus borderline personality disorder. And this makes it very difficult then to determine who might be most at risk for suicide. So as many of the speakers have already pointed out today, I think it's very important when we're talking about suicide to remember that it exists on a spectrum, all the way from possibly a passive desire for death to actually ideation of hurting oneself to the actual behavior and suicide. And when we think about this, then, there are also constructs that we want to be careful to consider within this spectrum. So if we're looking at ideation, some of the things we might be thinking about are anhedonia. We might be thinking about decreased cognitive flexibility or the ability to think of other options besides suicide. And we might be thinking about hopelessness. If we get over to behavior, the constructs might shift a little bit. Maybe now we're thinking about constructs like impulsivity, negative emotional reactivity, and also the lethality of actions. Because actually a lot of researchers have argued that high lethality attempters, or those who make the most lethal attempts, could represent a very different subgroup than the low lethality attempters, with high lethality attempters sharing much more in common with those who actually complete suicide. And so we will want to be careful about thinking about lethality of actions, as well as maybe some of these other constructs, if we want to contextualize and understand the general brain findings. And if we do that, if we try to understand these neuroimaging findings in the context of suicide, we can look at the general functions of the brain regions where we see the abnormalities, and then we can also try to start to draw some associations between those abnormalities and clinician-administered rating scales of symptoms and behaviors or other self-reports. So as just a brief example of this, if we see a structural abnormality in the ventral prefrontal cortex, like I had shown you, we might then start to think that perhaps this implicates emotion regulatory processes. Then, if we want to understand better how the brain might be responding to different emotional cues, we can introduce a task into the scanner and get some functional findings. So we might then look at the neural response to emotional face cues. And if you think back to a couple of slides ago, I'd shown you that we did see abnormalities in that frontal system when responding to both positive stimuli and negative stimuli. And then we can go a step further and think about maybe some form of self-report or other clinician-administered scale. And just one example, if we're looking at emotion regulation, might be the difficulties in emotion regulation scale. And there's drawbacks to each of these approaches, but they're a really important first step to help us better understand some of our findings that we see in the biology. And just to illustrate this, if we go back to that serotonin slide, certainly again we've seen the abnormalities in the serotonin synthesis, receptor binding, and transporter binding, But we've also seen associations between impulsivity and transporter binding, and hopelessness and receptor binding. And so this gives you a sense of how we can take one specific symptom that we see in the clinical room and link it to not only a brain region, because this was in frontal brain region, specifically ventral, but also to potentially a neurotransmitter system. And that's the holy grail. That's what we'd like to be able to do. So let's keep these things in mind, and we're going to move now into looking at some of the results related to borderline personality disorder. So actually, despite the prevalence in borderline personality disorder, there's been very little neuroimaging research. Perhaps that has to do with funding. So again, go sign that petition. But I want to focus on one 2012 study that looked at the gray matter structure in the brain in individuals with borderline personality disorder. And what they saw is that in comparison to controls, BPD attempters had less gray matter in areas that are involved broadly in emotion regulation, executive functioning, and behavioral control. So this included the ventral prefrontal cortex, including the orbital frontal cortex, or the OFC. That's the area right above the eye orbits and is the ventralmost component of the PFC. Also involved reductions in the hippocampus and parahippocampus, or around the hippocampus, and the insular cortex, among some other regions. So now we have these brain abnormalities. Let's think about function. So the orbital frontal cortex is involved in behavioral control as well as emotion regulation. So we can see how that would impact suicidal behavior. Also, the hippocampus, as I said, is involved in memory. But there's actually been some studies to say that attempters may have more difficulty with certain retrieval of autobiographical memories, specifically the positive autobiographical memories. And what this means is that these individuals may have more difficulty than envisioning a future positive outcome based on their past experience. And you can see how this might contribute to thinking that suicide might be the best option in this moment. The insula, as I mentioned, is really quite complex. It has a lot of connections with the OFC, the amygdala, hippocampus, and other connection sites. And it is involved, among other things, in, again, the internal monitoring of affective and physical states, including pain. And I think this one is really interesting because you hear a lot of clients coming in talking about just very visceral feelings of pain involved in the emotions that they're experiencing in and around suicide attempts. And the other interesting aspect of function that the insula has is that it's related to mirroring responses in others, and mirroring emotional responses in others. So these authors were also interested in looking at some of the constructs that I had mentioned, and they focused on lethality of attempt in this particular study. So they took their attempter group, and they broke it down into high lethality and low lethality groups, and looked at how the two groups might differ and how these results in the overall attempter group might compare within this subsample. And what they saw actually is that high lethality attempters differed in many of the same regions from low lethality attempters as the overall group did from controls. And this included the OFC and insula, also the parahippocampus, which isn't really pictured here, so I didn't list it. But really what this tells us then is that structural abnormalities may be able to differentiate between high lethality and low lethality attempters, at least in this diagnosis. And that's really important if we consider our hypothesis that perhaps high lethality attempters share more in common with people who complete suicide if we ever want to get to a place of identifying people more at risk. And again, people can shift between low lethality and high lethality attempts, but it's a start to begin to unpack risk factors for later suicide attempts. So again, these areas are broadly involved in emotion regulation, behavioral control, and executive functioning, and that can represent this biological vulnerability or some of the mechanisms behind this vulnerability. But oftentimes, this isn't enough in order for there to be a suicide attempt. There's also usually a proximal trigger, correct? And I understand that, again, people with borderline personality disorder will often have really chronic ideation for years and years, and we certainly can't underestimate the effect of long-term stressors like childhood maltreatment. But I also think that if we look closely at an attempt, there's often a very more recent trigger. And what we've heard about today, actually, in a couple of the talks then, is that interpersonal difficulties are often a trigger for people with borderline personality disorder. And the reason this is very interesting is that actually the structures that I just spoke about, which have those functions and those other functions that I mentioned, also are implicated in interpersonal responding. So the OFC is important in responding to individuals, either impulsively or not impulsively. And also, the insula in particular is associated with things like cooperation, rejection sensitivity, and self and other awareness or empathy. So if we go back to the first talk today, Dr. Kane's talk, she spoke a lot about this idea of perspective taking for self and others as being important in borderline personality disorder, and I kind of perked up because I was like, oh, well, that maps on lovely, because the insula actually has some roles in that exact thing, and this was a finding in their study. And it might be something that we want to be thinking about in relation to suicide and borderline personality disorder. The other thing that I found quite interesting is that, again, the original comparison was in all attempters for borderline personality disorder compared to controls. But they also looked at attempters versus non-attempters. And the only structure that came up as different was the insula. And so this could mean a lot of different things. It might mean that there are some shared vulnerability for suicide across attempters and non-attempters in borderline personality disorder. Just one example might be that they share some vulnerability to emotion dysregulation and behavioral control. And that would make sense given the diagnostic criteria, correct? But it might also mean then that perhaps those who go on to make attempts, if the insula is a structure that might differentiate, then maybe these individuals have just slightly more sensitivity to some of these interpersonal difficulties. And simultaneously, they might have slightly more trouble identifying how their behaviors might impact other people. And this is just one hypothesis, and it would require a lot more study, but it's interesting for us to think about when we're considering all of the talks that we heard today. But the authors then hypothesized that suicidal behavior and borderline personality disorder can often be linked to these interpersonal triggers, and that disruptions in the OFC, the hippocampus, the insula, and some of these other structures might limit the brain's ability to respond adaptively to these particular kinds of social structures by disrupting the functions of those brain regions that would allow someone to respond with different emotion regulation strategies or to inhibit their impulsive behavior. And this is really in line then with what's called the Diathesis-Stress Model, which was alluded to in a couple of talks, which is proposed by Dr. John Mann out of Columbia University. And in this, we have a biological vulnerability. And so in borderline personality disorder, this would maybe be the OFC, hippocampus, insula, and these other related structures. And then this biological vulnerability is impacted by things like genetics, which I didn't have a lot of time to get into today, but certainly genetics can have an influence. Also the environment factors, childhood maltreatment being just one example. And also hormones, sex, stress hormones being a couple of examples of this. And each of these can have an effect on the neurodevelopment of these brain structures during adolescence and young adulthood, leading potentially to structural abnormalities, and also then abnormalities in the functioning of those regions that might contribute to risk for suicide. And this is the diathesis. But again, not everybody with emotion dysregulation vulnerability is walking around dysregulated all of the time. So there tends to be a more proximal emotional stressor. Again, in the case of borderline personality disorder, maybe more often an interpersonal stressor. And this leads to a loss of cognitive control through a disruption of the functions of those regions that we saw the structural abnormalities, which leads to an increased likelihood of impulsive, aggressive behavior, self-destructive behavior, and potentially, ultimately, suicide. But again, not everyone with borderline personality disorder will attempt suicide, and certainly not everybody has the same trigger or reason for suicide, but this is something for us to kind of consider. So in summary, BPD attempters had lower gray matter volume in regions involved in emotion regulation, behavioral control, executive functioning, and interpersonal responding to social situations. We also see then that structural differences may be able to differentiate between high and low lethality subgroups. And we see that it is possible that during times of stress, maybe particularly during times of interpersonal stress, the behavioral functions of those structures are disrupted, leading and contributing to suicidal behavior. So now let's turn then to how this might compare to other psychiatric diagnoses, using the work done in our lab and a focus of my research on bipolar disorder as one example. So in thinking about how borderline personality disorder might compare with other diagnoses, there's actually been really few comparison studies, so there's not a lot to go on. That's really any diagnosis compared to another diagnosis in this particular field. And also, to complicate matters, the methodologies differ widely across research sites. So how one group might be looking at gray matter data could be very different than how a different group might be looking at gray matter data, or one group might be looking at structure, another at function, and that may make it difficult to draw conclusions about the underlying mechanisms. And thus, we don't know exactly what might be shared abnormalities across diagnoses and be similarly targeted for treatment and intervention, and which might be unique and require some more tailored approaches. And so essentially, we kind of don't know whether we're comparing apples to apples or apples to oranges here. And so we have not had the chance to do a direct comparison between borderline personality disorder and bipolar disorder that we'd really love to. But we did want to show and look in bipolar disorder attempters and to look at the neural mechanisms in this diagnosis, and that's what I'll share with you. And we really wanted to focus on that developmental time period. So we looked at ages 14 to 25. And like I had mentioned, what makes comparison difficult is that a lot of groups will be using multiple methods to look at suicidality within the same sample. And so we really wanted to use a multimodal approach to looking at this in bipolar disorder. And so we looked at gray matter, like the structure like I shared with the borderline personality disorder sample. And then we also looked at white matter. We're using diffusion tensor imaging, which I talked about at the beginning of the talk, to look at the white matter integrity. And we also looked at functional connectivity, or the way different regions of the brain communicate with one another. And we focused on connectivity then with the amygdala, which, as I mentioned, is an emotional center of the brain. It's really involved in emotional responding. It's implicated in emotion regulation. And in other samples, it's been shown to see some structural abnormalities in attempters. So what we saw then was a decrease in gray matter volume in the OFC and the hippocampus and the cerebellum. So I'm hoping that some of these brain regions are starting to look really familiar by now. And that's because we did indeed see some overlap with the borderline personality disorder sample, and that we saw a reduction in volume in the OFC and the hippocampus. So this would suggest, even though it's two very different studies, that there might indeed be some shared vulnerability to suicide behavior. And if we think about the functions of these regions, maybe that shared vulnerability is in emotion dysregulation, as well as in how memory processes are used in the middle of crisis. And it also suggests that there might be some areas of difference, because we didn't see a difference in the insula. And this, I think, is also important because Dr. Kane had talked about the impairment in object relations wasn't a general risk factor, but specific to borderline personality disorder. And so again, that research is very separate and different, but it is interesting that potentially there are general risk factors for suicide behavior, and there might also be very specific risk factors within a diagnosis. Then we went on to look at the white matter, and we saw connections then or a reduction in white matter integrity in a structure called the uncinate fasciculus. And essentially, this carries major connections between the orbital frontal cortex and the amygdala. And this would suggest then that there might be some disruptions in how the orbital frontal cortex is able to communicate with the amygdala and vice versa if the integrity is compromised in this particular structure. We then went on to look at the functional connectivity with the amygdala, so how, again, the brain regions are communicating with one another. And we saw a reduction in connectivity between the amygdala and the ventral prefrontal cortex. So taken all together, the regions of the brain that we were looking at, the tasks that we used in the scanner, because this was during the processing of face stimuli, and fearful, happy, and neutral face stimuli, as well as the findings across modalities, really implicates an emotion regulatory system and circuitry as important for suicide in bipolar disorder, which might make some sense knowing what we know about the symptoms of bipolar disorder and the high extremes that they can have in their emotions. We also then wanted to look at how these findings might relate to one another. And so we wanted to look at whether or not there were relationships between the structure and function, because it would make sense that white matter might have an impact then on how the brain functions, or that the structures might impact functioning. But we really need to see some associations or relationship before we can draw that conclusion. And so we did look at associations between these findings and also with some of these other symptoms like hopelessness, impulsivity, lethality of attempt, and ideation. And what we saw then is that we did see an association between the decrease in white matter integrity and that uncinate fasciculus that provides the connection between the amygdala and the ventral prefrontal cortex, and the decrease in functional connectivity between the amygdala and the ventral prefrontal cortex. And so this might suggest a structure-function relationship, and also suggests that perhaps it inhibits the ability of the ventral prefrontal cortex to exert that kind of top-down emotion regulatory control over perhaps some hyper-responding to emotional stimuli in these bipolar disorder attempters. What also was very interesting is that we didn't see associations with hopelessness or impulsivity in this sample, but we did see that both of these areas of difference in the white matter and the connectivity were associated with suicide ideation. And so this suggests a mechanism of risk, or how these structure-function abnormalities are contributing to risk within this sample. And to illustrate this a little bit, in depressed youth, it's been shown that maladaptive emotion regulatory strategies actually increases suicide ideation, planning, and action, whereas adaptive emotion regulatory strategies can decrease suicide behavior. So it is possible that high emotion dysregulation in these individuals, contributed to by these kind of neural mechanisms of the abnormalities in the white matter and in the functioning, contribute then to an increase in suicide ideation, and thus potentially to an increase in suicide behavior. Also then, as it shows here, there was an association between that area of reduced connectivity and attempt lethality, with those who made higher attempts having even more abnormalities and that connection with the amygdala. And this is consistent with other adult studies showing hypofunction or reduced functioning in the frontal networks. And it's also consistent, at least in the region, with the borderline personality disorder sample that I showed you, because if you remember, the OFC was associated with, had lower gray matter volumes in those who made more highly lethal attempts than those who made low lethality attempts. So again, we're just trying to begin to understand how to parse out and differentiate between what is a really complex construct of suicidality. So in summary, for bipolar disorder then, we saw reductions in gray matter volume, we saw reductions in the white matter integrity, and we saw reductions in functional connectivity between the amygdala and the ventral prefrontal cortex. And we also saw connections between structure and function, with white matter connected to the connectivity, and we saw associations with particular symptoms, ideation, and lethality. And this together implicates that ventral frontal limbic system that subserves emotion regulation as important in bipolar disorder. And again, a couple of things to point out then. It does also maybe give us a sense, preliminary sense, of shared abnormalities with borderline personality disorder and some differences, and we can begin to maybe understand how we might be able to have targeted treatments for some diagnoses. That's going to be later as we really gain much more knowledge, because this is very preliminary. But it's at least a start to know that we can see the underlying neural mechanisms for why there might be differences and similarities across these diagnostic categories. And then also to point out again, this was in an adolescent subsample, So it gives us a little bit of a sense of how the brain might be developing and that link with then the development of suicide behaviors during that time period. But what it doesn't tell us is whether or not the children, before we got to this age, actually had abnormalities already, and that those might be predictive of later development of suicide behavior, or whether they really started out very, very similar until they hit adolescence, and then there's this altered trajectory during developmental time where there's disruptions potentially in the neural circuitry, and their paths start to diverge, because that makes a big difference in terms of how we treat and potentially prevent suicide behaviors in adolescence and on into young adulthood. So from there, it kind of segues into how can neuroimaging help us understand and prevent suicide behaviors right now, and how can we maybe apply some of this understanding of the neural circuitry in more clinical settings. And so I think one of the big take-home messages for you today is that we can see neural circuitry differences in attempters and associated with suicidality, and I hope that I've shown that today. However, or as we like to say in DBT, we have not reached the goal of identifying one particular risk biomarker. We cannot have someone go into a scanner and look at like a threshold of the volume in the orbital frontal cortex and say this person is going to be more at risk. We're not there yet. And what's more likely, because as it's been pointed out, this is such a complex and very interrelated issue, is that there's likely going to be many biomarkers, including interrelated systems, as opposed to just one. We can also know that neuroimaging paired with different assessment techniques like self-report can help us clarify our understanding of some of these brain findings to help us more contextualize these biological findings and how they might contribute to risk. However, this assessment is in really early stages. The study that I showed you in borderline personality disorder was the first, to my knowledge, in borderline personality disorder attempters, and that was in 2012. So it's been relatively recent, and since it is in such early stages, one positive finding really should not negate the possibility of other positive findings. And as just one example, I had mentioned the serotonin system is the most widely studied in relation to suicide, but it doesn't mean we shouldn't look in other places like dopamine, with reward processing, and look at potentially other neurotransmitter systems, which we have, but just not to the same extent. And at the same time, since this is early, these should not be considered definitive results, even my own study, but just as a place to start, that this is what we see as kind of a first round, and we really need to refine our knowledge and our understanding to get us closer to understanding the biological mechanisms behind suicide behavior. And next, neuroimaging can show us that there may be similarities and differences in the neural abnormalities across diagnoses, and we do not fully understand how those neural mechanisms work yet and how they contribute to risk within and across disorders. And this will be very important for us to understand as clinicians if we want to really tailor our responses to different individuals based, yes, on diagnostic criteria, but other criteria potentially as well, is to understand what really might be similar and different in these biological abnormalities in the individuals that we treat. So what can we do to help move our field forward then? And definitely we need more longitudinal studies in individuals known to be at risk for suicide. So I guess we saw today that we're not really sure who's at risk for suicide, but there are some things that we can look at, like those who are experiencing suicide ideation. And if we follow those individuals over time, we can potentially look at neurobiological predictors of attempts. Again, to try to understand, is this structural abnormalities or these functional abnormalities there early in childhood, in the younger ones who are already attempting? Or is this something about the development and an altering of the trajectory of development in these brain regions and these neurotransmitter systems that really contributes to risk over time? And we also need more multimodal studies comparing the similarities and differences across diagnoses if we're ever going to try to get to a place where we can really tailor our responses. And potentially, eventually, maybe we can begin to target neural circuitry in our treatment approaches and design and look as outcome measures some of these neural circuitry. And to illustrate that, I just want to quickly point out that actually some treatments for borderline personality disorder have shown an effect on areas of the brain that are implicated in suicide. And this includes the dorsal prefrontal cortex, the ventral prefrontal cortex, the amygdala, the hippocampus, and the insula, among other regions. But the important thing here is that they actually didn't look at suicide or suicide behavior as an outcome measure. And this would absolutely need to be directly assessed before we can draw any kind of conclusion about the effect on treatment, on neural circuitry, and then an effect on a reduction in suicide behaviors. So then, if we don't have a biomarker, and we can't place someone in a scanner and know whether or not they're more likely to attempt suicide, then what can neuroimaging help us do today? And I'd like to give you some suggestions, and I also want to be clear that this is not evidence-based treatment and that these strategies haven't been gone through randomized controlled trials. And I think that they can be helpful for some of the patients that we work with, and certainly when I think about going back in time, and if I were sitting across from that same patient that I had talked about at the beginning of my talk, these are things that maybe I would have wanted to be able to do with her. And the first is that I think that we can really explain that there are biological, including neural, vulnerability factors for why you might consider suicide as an option. And the reason I think this might be helpful, and I'm thinking about that particular client, and I think the reason it could help her is that she really struggled with guilt and shame. And that she, as well as probably many clients, has been told that thinking about suicide was just a really selfish option. And she struggled with that. And I think if we understand that there might be neurobiological underpinnings to these symptoms, like so many psychiatric symptoms, then it can start to alleviate some of that guilt and shame and potentially stigma and lead to increased understanding and validation among our clients, certainly, also among peer and family caregivers and us as clinicians, for sure. I also think then we can explore how the neural mechanisms that confer risk for one diagnosis and one individual might be different from individual to individual. And that we can take then a curious, non-judgmental stance to exploring these things with our clients. Let's recruit them and trying to understand how their brain might be vulnerable. And you might use language like, do you think, looking back at that particular episode, that your brain might be more vulnerable to just responding in ways that you didn't even want to respond to in that time, or that you struggle in just responding to people in particular, into this interpersonal arena? Or is it really that your emotions just start to feel unmanageable? And in that way, then, we can really start to think about these vulnerabilities and strengths, because there's, along with vulnerabilities, there's a lot of strengths in every individual, but they can be personalized. And also, as just a side note, I think for some individuals, and it requires some clinical judgment, like any technique that we use, but the slightly distancing language of talking about, do you think your brain might have vulnerability? For individuals who are really high, have very high shame, it feels somehow different than, do you think you struggle with emotion dysregulation? There's a couple of individuals that I'm thinking of where that's really helped them enter the conversation in just a slightly different way when I got kind of stuck with them when they were experiencing a lot of high shame. Again, it's not going to be the same for every client we work with, but there might be something about shifting up language a little bit that might be helpful for some individuals. Next, we can encourage our clients that the brain is plastic and able to change and learn new ways of responding. And this is so important because it is not that the brain is damaged. That is not at all what we're talking about. And it is not, there are vulnerabilities, like there's vulnerabilities to everything. People walk around with vulnerabilities to cancer and to different other symptoms and behaviors that range from psychological to physical. There are vulnerabilities, but there's absolutely the potential for change. So we really want to discourage that kind of fatalistic thinking of like, oh, this is my brain and this is the way it's going to be and it will always be and there's nothing I can do about it. No. We want to actually encourage that responsibility for change, because what is true is that these alterations in circuitry don't happen overnight. That probably the circuitry that's seen many repetitions when engaging in suicide ideation and behavior over the course of this person's lifespan is we're going to require many repetitions of learning new ways of thinking and behaving. I was so grateful for the talk earlier from the young woman who shared, because her story kind of tells it. She kept at it. She kept practicing and practicing and practicing, and that's how we can start to change the neural circuitry. It's not going to happen overnight, and we can't do it for our clients, but we can encourage them to begin to change the circuitry for themselves. And that really is the message that we want to transmit, is one of hope. Because what I hope I've shown you today is that there can be a link between these, the symptoms of suicide and the behavior of suicide and biological factors. It starts with an impact of genes and hormones and stress, both early and later stress, that this can impact neurodevelopment, leading to perhaps to abnormalities in potentially a frontal brain system, including gray matter and white matter, structural abnormalities and function abnormalities, that might contribute to risk for emotion dysregulation, reduced executive functioning, and behavioral dyscontrol, and ultimately to suicide. But this also gives us many points of intervention, starting potentially with early childhood stress and stress throughout the lifespan. We can intervene there. Maybe we can intervene during neurodevelopment to steer these neurodevelopmental trajectories back on track. Maybe we can intervene with different behavioral and psychopharmacological approaches to affect the structure and function of the brain, to have an effect then on the symptoms and ultimately lead to a reduction in suicide behavior. So with that then, I'm going to end here. I really want to thank my research lab. There's so many people, I really couldn't list them all, but I do thank everybody. And also my clinical supervisors, current and past, and some of the people from my DBT consultation team who are here today. Their clinical guidance and insight really does inform the work here today, and so I'm very grateful. So, thank you.
Thank you, Jennifer. We have one question that focuses on so a lot of the researchers today talked about the sense of self and maybe an unstable sense of self. Were there any findings with regards to suicidal risk that were in regions that might overlap with how a fluctuating sense of self is implicated?
Yeah. And so broadly, actually, the insula also would be involved in that sort of the sense of self, the monitoring and awareness of yourself and other people. So it's an awareness of your sense of self and also an awareness of other people and the mirroring of emotional experience. And there can be other associated brain regions, but just in terms of what I talked about today that had come up in a particular study, the insula would be potentially involved in processes like that.
Okay, wonderful. Thank you so much, Jennifer.